Hello everyone. I hope that you all are doing fine. So we will start with our today's pages, which we will start from this page, which states that cross reactivity between beta lactams. So I'm sorry about my cough. Beta lactams are a type of antibiotics which does contain beta lactam ring in their structure. More commonly, the antibiotics are penicillin, cephalosporins, carbapenems, and monobactam. So I'll just explain you through this diagram. So this is the structure of penicillin and this is the structure of cephalosporin. So can you see here that this beta lactam ring is similar? They both of them does contain beta lactam ring, and previously it was thought that if the patient is allergic to penicillin, there are 10% chances that he would be also allergic to cephalosporin because of their similar kind of structure. But now it has been found out that the allergic reaction is not from this structure. They are mainly dependent on this R1 or R2 side group. So this is the thing. So that's the reason now the chances of allergic between cross reactivity between penicillin and cephalosporin has moved down. Okay, so we will start from here. However, recent evidence and clinical experiences suggest that the most reaction occurs in response to antigenic molecule in the R1 side chain that distinguishes individual penicillin and cephalosporins from one another. So previously it was thought that the beta lactam ring is the main cause, but now they mentioned that the R1 side chain is the thing which is causing the allergic reaction, and their R1 side chain is different from each other, so the chances of cross reactivity is lesser. The prevalence of cross reactivity between beta lactams is not known precisely. It is common misconception, like we have read this misconception in previous pages as well, where previously we used to thought that if the patient is cephalosporin allergy occurs in approximately 10% of patients who are allergic to penicillin. However, the recent reviews shows that overall only 1 to 2% of patients with a confirmed penicillin allergy have a cephalosporin allergy. So it moved down to very low level. Then cross-reactivity is more likely in patient with an amoxicillin or ampicillin allergy who receives cephalexin. Okay. So they say that if the patient is allergic to amoxicillin or ampicillin, then there are more chances that the same patient would be allergic to a type of cephalosporin, which are cephalexin and cefaclor. What is the reason of that? Because they do have similar R1 side chain. So I'll explain you through this diagram here. So can you see this is the structure of the ampicillin, amoxicillin, cefaclor, and cephalexin. Okay, sorry, amoxicillin structure is this one, but this is the R1 side chain. They four of them share the common side chain. So if the patient is allergic to one of them, then he would be allergic to four of them because they do have similar R1 side chain. Okay, then beta lactam cross reactivity is more likely in patients with amoxicillin or ampicillin allergy who is sorry, it's the all same line. Then cefazolin has no side chain with the other beta lactam, so is often tolerated in patients with a penicillin or a cephalosporin allergy. So as were reading before that the allergic reason of allergy is the R1 side chain. Okay, but you can see here cefazolin, it does not have any side group which is similar to any of these. So it means this type of cephalosporin is safe to prescribe even in the patient who are allergic to amoxicillin, ampicillin, or any other penicillin. Okay, then in patients with penicillin allergy confirmed on testing, the rate of immune mediated cross reactivity with carbapenems is approximately 1%. There is no cross reactivity between penicillins and monobactams. Then in settings where allergy testing is not available, and a beta-lactam antibiotic is the preferred drug antimicrobials to avoid based on potential cross-reactivity. So now they have written here, like for example, you are in a setting where the allergic testing is not available to you, okay, and you are in this condition where you need to prescribe the antibiotic to the patient in today's appointment only. Here they have written like which antibiotic you should avoid. So, if the patient is allergic to amoxicillin and ampicillin, you should avoid cephalexin and cefaclor. Okay, and then if he is allergic to ceftriaxone, then you should avoid cefotaxime, cefepime, ceforexim. Then, if the patient is allergic to ceftazidime, then you should avoid aztreonam. So these antibiotics we don't really prescribe in any of the prescription according to this book, but you should just remember for your knowledge. This could be the most important point from these three, like the cephalexin and cefaclor. But you should just keep in mind about these things, that you should not be prescribing these drugs to your patients if they are allergic to these antibiotics. Okay. In patients with immediate severe penicillin hypersensitivity, for example, anaphylaxis or angioedema, avoid penicillin and cephalosporin in most situations. Okay, and however, in a critical situation when a beta-lactam is the preferred drug, a cephalosporin can be considered after undertaking a risk-benefit analysis and assessment of a potential side chain reaction. But even if you are in doubt, any doubt, uh, do not think like I am a dentist, I should know this. They do not expect you to be more experienced or more ready. They just expects you to be a junior dentist, so you can always ask for help. Okay, so asking for help is not a bad choice. You should always ask for before giving patient anything. You should be so sure in your mind that you are doing the right thing. And if there is a 1% confusion, you should always clear it out before prescribing any drug or before doing any irreversible treatment. Okay, so as they mentioned in the previous pages, do not try the approach of let's try this or just in case. You should be sure. Okay. Then in patients with delayed severe penicillin hypersensitivity, like if the patient has DRESS, then Steven Johnson syndrome, or those like fulminating reactions, then do not use any cross reactivity to guide treatment and avoid all penicillins and cephalosporins. Then cross reactivity between sulfonamides. Antibiotic sulfonamides, example sulfomethoxazole, sulfadiazine, and dapsone, are often avoided in patients who are allergic to non-antibiotic sulfonamide, which is furosemide. So they states that often it is avoided if the patient is allergic to furosemide. We do not prescribe him sulfomethoxazole, sulfadiazine, and dapsone. However, this is usually not necessary because, with one exception, there is no cross reactivity between antibiotic and non antibiotic sulfonamide. The exception is sulfasalazine, a non antibiotic sulfonamide that is structurally similar to sulfonamide antibiotic. Avoid sulfasalazine in patient with antibiotic sulfonamide allergy and vice versa. Alright, so I think this is too much. So I'll just explain you in brief. So there are two types. Okay. So first is antibiotic sulfonamide and the other is non-antibiotic sulfonamide. Previously, it was thought that if the patient is allergic to antibiotic sulfonamide, then do not prescribe him non-antibiotic sulfonamide. Okay. But now the recent review states that even if the patient is allergic to antibiotics sulfonamide, you can prescribe him the non-antibiotic one, but there is only one exception, which is the sulfasalazine, which you should not be prescribing. But again, according to exam point of view, I have not really seen any question in regards to this, but just keep in mind all these things. Furthermore, evidence shows that the rate of immune-mediated cross-reactivity within the antibiotic sulfonamide group is lower 9 to 12%. Then previously it was thought that between them the cross reactivity is around 20%, but now the recent review states that it's only 9 to 12%. And therefore, these antibiotics could be used in a patient with a history of either non-severe allergy to another antibiotic sulfonamide. However, this does not apply in patients with anaphylaxis or a severe cutaneous adverse reaction such as drug rash with eosinophilia and systemic symptoms. Like, if the patient has a history of severe delayed type of drug reaction or anaphylaxis, you should not be trying any other drugs, right? Okay, always take advice. You should not be taking the decision in those cases. But if the patient has only mild or like only the rashes or mild cases, then you can try it. But I would say always in that those cases also always take advice from your specialist or from your senior. For more information about allergy to sulfonamide, you can read it from this website. All right, so this is all that we have read here. Even like if the patient is, you should not be like all these structures, they are similar, so that's why try avoiding them. And estronem and ceftazidime, they have similar structure, so try avoiding vice versa. Okay, so antimicrobial drugs used in dentistry. This topic will cover. So this is only the intro part in which they have stated that always whenever you will prescribe any drug to the patient, always weigh the benefit and harm profile of the drug in the individual patient. You should also this require knowledge of the patient's medical history and concomitant medication, like which other medication he might be taking, including prescription, over the counter, and complementary medicines. For example, like the contraceptive pills, you should know about them as well, because there are some cross reactivity between some certain drugs. Then the antibacterial drugs used in dentistry. First, we will start from cephalosporins used in dentistry. These, as we studied in the last pages, they are beta-lactam antibiotics. In the majority of patients, cephalosporins do not cause significant adverse effect. However, some patients are hypersensitive to one or more beta-lactam antibiotics. Widespread use of cephalosporin can cause MRSA, which means that multi-drug resistant, methicillin resistant Staphylococcus aureus infection. So this is a type of infection in which the antibiotics does not really work, and it is very prevalent these because of these cephalosporin and vancomycin resistant enterococci and multi-drug resistant gram-negative bacteria. So here they are stating that if you will over prescribe cephalosporin, it can increase the prevalence of these resistant infections. And Clostridium difficile. Then the moderate spectrum cephalosporin that we will use is the cephalexin and the cefazolin have similar spectrum of antibacterial activity. They are active against streptococci and staphylococci, but inactive against MRSA, so which is the resistant one, and some anaerobes. In some circumstances, cephalexin and cefazolin can be used as penicillin alternative in patients hypersensitive to penicillin. So penicillin used in dentistry, they are also a type of beta-lactam antibiotic. In the majority of patients, penicillin do not cause significant adverse effects. However, some patients are hypersensitive to one or more beta-lactams, so you need to consider that. So there are a few types, right? So narrow spectrum penicillin. So narrow spectrum are always better because they are only acting against certain type of organism, and they do not really cause much effect and increases the chance of resistance as compared to moderate, and the broad one has the most chances to cause the resistance. Okay, so which are the narrow spectrum penicillin? First of them is the benzyl penicillin and the phenoxymethyl penicillin. Narrow spectrum penicillins are active against numerous oral pathogens, which include Peptonephilus, then Actinomyces, then Streptococcus species, and other oral anaerobes like Fusobacterium species. They are inactivated by the strains that produce beta lactamase enzyme. So, if the bacteria which are producing beta lactamase enzyme, they can inactive these antibiotics, and these antibiotics won't be helpful in those cases. Okay, so the benzyl penicillin is basically known as penicillin G, is given parenterally. So parenterally, it means that you should give it IV. So benzyl penicillin is given IV, and IV antibiotics are only given in hospital. As a dentist, as a general dentist in the clinic, you should not be giving any IV antibiotics. Okay, so for susceptible infections, like if there is a spreading or neurogenic infection with severe or systemic features, if it means that if the patient has fever, or if the patient can has the problem in swallowing, talking, breathing, then these antibiotics are given, and they are given through IV route. They are given in the hospital. The IV route is best because we need the high amount of antibiotics at very less time. Like it's an urgent treatment, right? It is the treatment of choice because of its narrow spectrum of activity. Then phenoxymethyl penicillin is also known as penicillin V, and it is given orally. For susceptible organism, phenoxymethyl penicillin is preferred to amoxicillin because of, like, as we discussed before, like if the narrow spectrum is better than the moderate is better than the broad spectrum. Okay, because more broad we are going towards, it would increase the chances of resistance. Food impairs the absorption of phenoxymethyl penicillin. Ideally, it should be dosed at 6-hour intervals, but for practical purposes, 4 times daily dosing, evenly spaced during waking hours, is often used half an hour before each meal and at bedtime. So you all must know that antibiotics does not go well with the food. So we should advise patient to take it before food. Okay, and ideally it should be given 6 hourly, but for the practical purposes you should divide it into the waking hours. Like if the patient wakes up at 6 a.m. and sleeps over 10 p.m., then you should divide it into 4 times daily and then prescribe the dose. Then there is other type of narrow spectrum penicillin which also has the anti-staphylococcal activity. Okay, so these are the dicloxylene and flucoxylene. Dicloxylene and flucoxylene are active against streptococci and staphylococci but inactive against MRSA. They are recommended as first-line treatment for many skin and soft tissue infection. You all know that the staphylococcal infection is mainly the skin infection, right? So these antibiotics we generally prescribe if the patient has patient need any skin treatment or soft tissue infections like acute suppurative silodenitis. Food impairs the absorption of these antibiotics as well. Ideally, they should be dosed at 6-hourly interval, but for practical purposes, 4 times daily dosing, evenly spaced during waking hours, is often used. Example, half an hour before each meal and at bedtime. So this paragraph is similar to this one. Rarely, flucoxetine is associated with cholestatic jaundice. So, flucoxetine can put effect on your can cause cholestatic jaundice, and particularly in older patient or prolonged therapy. Cholestatic jaundice can occur after oral or IV administration and up to 6 weeks after the treatment. And the dicloxazine appears to cause less irreversible hepatotoxicity but causes more interstitial nephritis. So you can just remember that flucloxacillin is more put more effect on liver, okay, and dicloxazine put more effect on kidneys, but these are rare and these usually happens if the treatment is prolonged. Then the other ones are the moderate spectrum penicillin, which we commonly prescribe to the patient, which are amoxicillin and ampicillin. They are active against the pathogens treated by all like the narrow spectrum antibiotics, whichever we read here, like all these peptinophilus, actinomyces, streptococcus, and oral anaerobes. They are active against all those. However, they have a broader spectrum of activity. Like they are active against large number of microbes as compared to the narrower one. They are inactivated by strains that produce beta-lactamase enzymes. So we all know that to fight with this beta-lactamase enzyme, we have this clavulanate. Okay, so clavulanate, when added with the amoxicillin, it brings the spectrum to be broad because has little but the clavulanate does not have any antibiotic property, antibacterial property, but it just helps to kill this beta lactamase enzyme, sorry, it is an inhibitor. It inhibits the beta lactamase enzymes produced by several bacteria, including Staphylococcus aureus and Bacteroides fragilis. The spectrum of activity of amoxicillin is significantly broadened. Okay, so if because we know the amoxicillin can work against many microbes, but it does not work against the microbe which does produce this enzyme. So if we have something that is fighting with this enzyme, then this can safely work against most of the bacteria, right? Because of its broad spectrum of activity, amoxicillin and clavulanate has a limited role in the treatment of odontogenic infection. It is used when narrow spectrum regimes are not suitable. Additional treatment for anaerobic bacteria, metronidazole, is usually not required. So if you are prescribing the patient amoxicillin plus clavulanate, there is no need to prescribe metronidazole because their activity is broad. Okay, but if you are only prescribing the amoxicillin, then you can prescribe the metronidazole as well if there is any anaerobic infection in the patient. Then IV amoxicillin plus clavulanate has an emerging role in Australia and is recommended for a limited number of infections in the guidelines. Then the other types are the folic acid antagonist used in dentistry that are trimethoprim and sulfamethoxazole. These act by inhibiting bacterial folate production. You all know, right? The bacteria, they have certain, like they do form certain cycle. So these antibiotic work, these are different stages of types of antibiotic which work against those cycle at different levels, so that's why they are divided. The primary indication in dental practice for the combination of trimethoprim and sulfamethoxazole, which is also known as cotrimoxazole, is the treatment of S. aureus infections in patients hypersensitive to penicillin and community associated methicillin resistant Staph aureus infection. So they are mainly used for Staphylococcus aureus infection, like the skin infection. Some patients are hypersensitive to, like as we read before, the cross reactivity between the sulfonamide antibiotics. You can read about them, and if the patient is sensitive to them, then we should avoid some. So keep in mind. And the other thing is that trimethoprim inhibits the tubular secretion of creatinine, which can elevate serum creatinine without any true decrease in GFR. Trimethoprim also inhibit tubular excretion of potassium and can cause hyperkalemia. So this trimethoprim act on the kidneys of the patient. It inhibits the tubular secretion of creatinine. Okay, and it also inhibit the tubular excretion of potassium and cause hyperkalemia. So in blood, the potassium level increases. Monitor serum potassium after 3 days of treatment with trimethoprim in patients at increased risk of hyperkalemia. Example, patients with, if the patient already has any kidney impairment, then you should be more cautious if you are prescribing him the trimethoprim. Alright, then glycopeptides used in dentistry. The primary indication in dental practice for the parental glycopeptide, which is the vancomycin, is the treatment of infection with MRSA. It is not as effective as beta lactams in the treatment of SRS infection that are susceptible to beta lactams. So, vancomycin is associated with the selection of glycopeptide resistant bacteria, and yeah, so this vancomycin is mainly the treatment of choice in case of MRSA. Okay. Then lincosamides used in dentistry, those are mainly the clindamycin and the lincomycin. They are active against most anaerobic bacteria, like same as the penicillin ones, and some aerobic bacteria, for example, Staphylococcus aureus and most Streptococcus species. In dental practice, lincosamides should be reserved for the patient, so they are generally prescribed to the patient if they are allergic to penicillin. Although clindamycin is inherently more active than lincomycin, that's why we generally prescribe clindamycin if the patient is allergic to amoxicillin or any other penicillin. For most indication, the same dosage is appropriate in these guidelines. Clindamycin is ranked preferentially to lincomycin because there are more clinical data to support its use. Clindamycin and lincomycin have similar adverse effects. They can both cause antibiotic associated diarrhea. There is no liquid formulation of clindamycin currently marketed in Australia. However, a 10 milligram per ml clindamycin solution can be made by dispensing the content of a 150 milligram capsule in 50. So this is just a mathematic calculation that they have done. They said that liquid formulation is not yet available. So if in case you need to give the patient the liquid formulation, then you can make it by dissolving the 150 milligram capsule in 15 ml of water. Then you can the patient can take 10 mg per ml. The solution should be shaken and stirred until an even dispersion is formed, and the required volume should be measured immediately. The dose can be mixed with the juice or soft food to disguise the taste before administration. The solution should be prepared immediately before administering each dose, and any remaining solution should be discarded. It's not like you just mix and make whole bottle at once. You should mix and shake well before taking each dose, and if there is any leftover you should discard it. Okay, so we will continue from these pages in the next video. All right, thank you so much for watching my videos, and see ya. Bye.